Kujofos. I'm a CPA medical student. And today we are going to discuss a very important topic which is prevalent in our setting here in Ghana and Africa. So before we start, we are going to start with a case study. So we have a 35-year-old woman, Gravida 1 para 2, presents at 32 weeks gestation, who presents with preterm labor. The pregnancy was complicated by gestational diabetes. Delivery occurs via vacuum extraction, and then the mother's blood group is O positive. 8 hours after birth, the newborn develops respiratory distress, which is characterized by shortness of breath, increased respiratory rate. And then there's a noticeable yellowish discoloration of the skin. Going through this scenario, we know the obvious diagnosis will be neonatal jaundice, right? Neonatal jaundice is the development of increased levels, or when there's increased levels of bilirubin as a result of certain things that the neonate is predisposed to, right? And this increased bilirubin levels are what causes the yellowish discoloration of the skin, right? Now, in most cases and commonly it is benign, right? But in some cases it is very serious, and we are going to discuss when it is benign and when it is not so benign, right? So talking about the causes, we said 1, they can be caused by conditions that cause increased breakdown of red blood cells. Second one can be caused by conditions that cause decreased conjugation of bilirubin. And thirdly, it can be caused by conditions that cause decreased excretion of the bilirubin. When red blood cells break down, they release the hemoglobin. Hemoglobin can be divided into the heme and the globin components. The heme component is made up of the iron and then the porphyrin rings. So the porphyrin rings are what break down to what are converted to the bilirubin. There's a whole process it goes through. Maybe we'll cover that in another video. So when you have your bilirubin formed, it's usually unconjugated, and this bilirubin that's unconjugated is in the bloodstream bound to albumin, and it's being carried through the body to the liver for it to be conjugated. Now, if you have a disease process that causes increased breakdown of these red blood cells, then you have a lot of this unconjugated bilirubin in the bloodstream, and that is what will lead to the yellowish discoloration of the skin. Now let's move on to the second process, the conditions that cause decreased conjugation. So there are some conditions that affect in the liver. You have enzymes that cause conjugation, that conjugates the bilirubin. The conjugation makes the bilirubin convert it from an insoluble form to a soluble form so that it can be easily excreted. And you have conditions that diminish, or either the enzyme is not functioning well, or the enzyme is not present in these conditions. And these conditions cause the unconjugated bilirubin to back up, and that's what causes the yellow discoloration of the skin, because they are not being conjugated and it's not being excreted. Then finally, you have conditions that cause decreased excretion of the already conjugated bilirubin, right? And then this one is plain and simple, because they are not being excreted. There's a backup which also affects the conjugation, and then you have a mixture of both conjugated and unconjugated bilirubin, causing the hyperbilirubinemia or the neonatal jaundice. Now, we can also group the causes of neonatal jaundice into 3 categories, right? A separate form of 3 categories, apart from the first one I spoke about. So you can have neonatal jaundice that occurs within 24 hours, and this kind of neonatal jaundice is almost always pathological. Like I said in the beginning, we have most of the causes of neonatal jaundice are benign, but we have some that are pathological or not so benign. So the ones that occur usually within 24 hours are usually pathological. And then you have ones that occur between 24 hours and 2 weeks, and you have ones that occur after 2 weeks. So let's take the first group of conditions that make neonatal jaundice appear in the 24 hours. So So conditions like the hemolytic diseases like AB incompatibility, resource incompatibility, G6PD. You can think of the hemolytic diseases, so like the ones I just spoke about. Also, congenital infections or neonatal sepsis can cause hemolysis, and then concealed hemorrhages. So concealed hemorrhages, like in the case of Kefa hematoma, right? They can all cause neonatal jaundice because of hemolysis. That's neonatal jaundice in the first 24 hours. Then between 24 hours and 2 weeks, these are more of you can have benign causes like breast milk jaundice, right, or physiological jaundice. You can also have other, like the ones we spoke about, like the infections, neonatal sepsis, and some hemolytic disease. They can also cause it after 24 hours, right? But then, after 24 hours, you have more benign causes like the breast milk jaundice or the breastfeeding jaundice and all those things, right? Then, after 2 weeks, you can still have the same causes, but then now you end up having more of the conjugated causes to as well coming in. So you can have your breast milk jaundice or the breastfeeding jaundice. You can have things like hypothyroidism. You can have conditions like bowel duct obstruction, neonatal hepatitis, and all those things. We have to make about 3 points. 1, fetuses or the newborns have high concentration of hemoglobin. That's the first point. The second point is that their red blood cells have a shorter lifespan. The normal lifespan of a red blood cell is 120 days, but for a newborn it is 70 days. Okay. The third point is that their liver is not mature enough to do the conjugation well enough. So those are the 3 points that we are going to base our pathophysiology of neonatal jaundice on. Right. So in this sense, you can even have neonatal jaundice without any condition occurring, because 1, the red blood cells are breaking down fast every 70 days, and they have high levels of hemoglobin in them, so they are releasing those high levels of hemoglobin, which is being converted to bilirubin. Now, we said that the liver is not well developed to conjugate these high levels of bilirubin, so then you have a backlog or a backflow, and that is what will lead to jaundice, neonatal jaundice. But this jaundice is physiological, because all these things that I've mentioned are normal for a newborn. Then you can have a case where something goes wrong, right? So you have the baby producing antibodies against, the mother producing antibodies which have been absorbed by the baby against the blood, and then you have these antibodies causing increased hemolysis. So instead of the normal 70 days, now the baby's red blood cells are breaking down faster. So they have even higher levels of bilirubin, and that is why they will present within 24 hours of birth. Right. Then you can also have other conditions that, so for example, the infections, neonatal sepsis. So sepsis, because of the increased, also because of the increased antibodies that are being produced, these antibodies also target red blood cells. They have increased breakdown of red blood cells. Even aside that, there are some medications that, when administered for, against infections, these medications, by way of their mechanism, can also cause jaundice. So we have an example like ceftriaxone, right, which when given, usually not given, but which when given can displace bilirubin from its binding site and then cause jaundice, right? So this is just the 3 factors that can cause physiological jaundice in a newborn and can also predispose them easily to jaundice. We mentioned that there was a 35-year-old woman, Gavida 2-1, who presented with preterm labor. So at a gestational age of 32 weeks, meaning that this child is premature, because prematurity in Ghana is, below between 28 to 36 completed weeks. So this child is premature. So prematurity is one risk factor for neonatal jaundice, because we said that already the newborns, the term newborns liver is not well developed. So imagine the pretense liver. Then we also said that the pregnancy was complicated by gestational diabetes. So what happens in gestational diabetes is, because in gestational diabetes the infants usually get big, macrosomia, they have macrosomia. They also tend to produce a lot of red blood cells. So they also have polycythemia. Right. Now, with this polycythemia, it means that the increased number of red blood cells with a high number of HB concentration is going to be breaking down every 70 days. So they have an even higher risk of neonatal jaundice. So the pregnancy being complicated by gestational diabetes also predisposes the child to neonatal jaundice. They also said that delivery was via vacuum extraction. Usually in vacuum extraction, because of the suction that's applied to the baby's head, it can lead to conditions like Kefa hematoma, those concealed hemorrhages, Kefa hematoma or subgilial bleed. And these concealed hemorrhages can also lead to hemolysis, and that is what would or may cause or may predispose this child to neonatal jaundice. So these are some of the risk factors we identified within our scenario, but there are more. There are more risk factors. Some risk factors like feeding. So if the child is not being fed frequently enough, right, there's something that occurs. So within the normal conjugation of bilirubin, right, after bilirubin has been conjugated and then excreted through the bile duct into the duodenum and is passing through the gut, it is reabsorbed back at the ileum and then goes back all the way. Some goes through the kidney, some also passes through the feces, some goes back to the kidney, excreted as in urine, some goes to the feces, excreted, and some goes to the gut, excreted in feces, and then some goes back and into the liver and then goes into the gallbladder again. So what this is called is the enterohepatic circulation. Now, if the baby is not being fed enough, not being given enough breast milk, right, the baby gets dehydrated. And when the baby gets dehydrated, there's increased enterohepatic circulation. So that means that instead of the bilirubin being excreted through feces and through urine, it's just going through the bloodstream. Just going round through the bloodstream, and that will eventually predispose the child to getting jaundice, because now the bilirubin is not being excreted at all because of the increased enterohepatic circulation. That's what poor feeding will contribute to. So a newborn with jaundice or a neonate with jaundice will most likely present with yellowish discoloration of the skin, the sclera, and even the gums. Right? This can be visible like without any intervention, or can be visible upon blanching the skin. Right? So in your clinical exam, usually the progression of jaundice is premenstrual. So you can blanch from the nose, the chin, the chest, the abdomen to determine the level of jaundice. And the level of jaundice can help you clinically to assess how high the hyperbilirubinemia is. Right? Apart from that, the stools will also be affected, because if there's a case that they are not, we said that the bilirubin usually excreted either through urine or through stool. So both of them. So in the case where they are not conjugating it well, or they are not conjugating enough of it, or it's not being excreted, then you have the stools looking, a bit strange. Some it may look greenish, it may look yellowish, but the normal stool looks brownish, and it may even affect the urine. The urine may start looking dark. So that's how usually they will present. And if it is very severe, then maybe they will present with poor feeding and then maybe lethargy. So the diagnosis of neonatal jaundice is clinical, right? So you diagnose it blanching the skin, looking for the yellowish discoloration of the skin and the sclera. Then, apart from making your clinical diagnosis, you also have to go for it to do some investigations to know the etiology, to rule out some of the things, right? So if a child presents within 24 hours with neonatal jaundice, I would want to know the child's blood group. I would want to know the child's hemoglobin level, their reticulocyte count. I want to do a direct and indirect scope, right? I want to do a peripheral smear, G6PD test, to know all these things, to help me either narrow down the etiology or see if there's some kind of complication. And then I would also want to do my bilirubin levels, so serum bilirubin levels, to know how high the bilirubin is and what kind of bilirubin is it direct or indirect, or conjugated or unconjugated. In our next session, we'll go into these details, discussing the various investigations that you can do after diagnosis, the various treatment modalities, and then some complications that can come out of the neonatal jaundice. So we'll end here for now and then see you next time.